ये नहीं, ये तो रख लो, उनको दे देना, वो यादव साहब जो कहाँ पे थर्ड लाइन में। I'll bring it. मैं ले आता हूँ। नहीं सर।
Respected chairpersons and dear friends, sorry for the inconvenience I caused to you, and I thank the organizers for accepting my request for preponing my talk. I'll be sharing with you about the treatment of non-unions of long bones, basically with plate augmentation and bone grafting, leaving the nail in situ. Despite advancements in fracture treatment, cases of non-unions of fractures following nailing are encountered in large number, and this affects patients' limb, body, economics, and psychological status, and it definitely tarnish the image of surgeon. Main reasons for non-union in long bone fractures, apart from other things, are basically mismatch between canal diameter and nail diameter. And predominantly it happens in distal fractures or in proximal fractures. And presence of comminution also leads to non-union. There are many treatment options for these fractures. I'll be basically talking about the aseptic non-unions.
ऐसे ही है, इसको बड़ा कर दो। अभी तो कुछ when I came, we came only 10 people in the house.
I'll be basically talking about aseptic non-unions. There are different options: dynamization, exchange reamed nailing with or without bone grafting, then nail removal followed by plating with or without bone grafting, external fixation, and then augmentation with plate fixation and bone grafting. Dynamization first. It is good for transverse or short oblique fractures, but you should have a well-fitting nail, and it should be done at appropriate time, that's around 3 months, and nail should have dynamic holes. Like if you have this kind of a nail, you cannot dynamize these fractures. And dynamization is questionable if you have extensive comminution, wide medullary cavity, long oblique fractures or spiral fractures, and if you have osteoporotic bone. So let's see what literature talks about exchange nailing. Exchange nailing is an excellent choice for non-comminuted diaphyseal non-unions. Not all long bone non-unions are appropriate for exchange nailing. And important considerations in decision makings are that there should be a definite osseous contact, then anatomical site, especially the distal fractures or proximal fractures, they are not fit for dynamizing, and you should not have a deformity. How it works? Biologically, it increases periosteal blood flow and periosteal new bone formation. And reaming products containing osteoblasts and multipotent cells, they serve as local bone graft. But I have my doubts whether these reaming provide sufficient reaming products and whether these products penetrate the fibrous tissue at the non-union site. Mechanically, a good optimal effect can be achieved when a good contact between thicker exchanged nail and reamed bone can be achieved on both sides of the fracture. And this is difficult if you have a wide medullary cavity on one side of the fracture. And you can increase the mechanical effect by increasing the number of screws. Now, results of exchange nailing are encouraging in some series like Wu and Chen. They could achieve union in almost 95 to 100% of patients. But apart from that, not many good series having exceptionally good results. And then in comminuted fractures, only 50% union could be achieved with exchange nailing.
You are the best.
Exchange nailing in tibia, again 1 or 2 good series. And in humerus is terribly bad, just 40% union rate. So biomechanically, rotational stiffness of interlocking nail is only 3% as compared to 55 to 70% of bending stiffness. So intramedullary nails, which are not canal filling, reduce the stability in bending and rotation, and too much motion in these complex fractures, they result in unpredictable mechanical strength. So does the exchange nailing provide enough rotational stability, particularly in comminuted fractures and non-unions at site of wide medullary cavity? So I tried my hands at plate fixation and bone grafting, leaving the intramedullary nail in situ. Nail acts as a load sharing device, maintains alignment, and plate finishes whatever the remaining rotational motion is there, and then you add autogenous bone graft to stimulate healing. This is what I could get from the literature, 5 or 6 series, but small series, less than 40 patients in each series, but all of them, they could achieve 100% unions in all femur fractures, and one series had 84% union in tibial fractures, so very encouraging. My experience in my hospital in last 13 years, I have done around 200 of these non-unions, majority of them in femur, few in tibia, and very few in humerus, and I have a long follow-up of these patients. Different kinds of nail had been used in these patients, starting from ender nail, but majority of them had interlocking nails. And majority of these fractures were comminuted fractures and high energy trauma. Very simple procedure, expose the bone and raise good osteoperiosteal flaps. That is the key. Then plates were chosen according to the bone. You can either use a narrow DCP or a broad DCP, and sometimes even the plate for the forearm can be used in tibia. At least 4 cortices, but I prefer 6 cortices on each side. And after plating, visible motion at fracture site must disappear. And then bone graft is added. You can use Mueller clamps whenever you feel like. If there is a gap at the fracture site, you can use this clamp. So few clinical examples, a long-standing non-union in the proximal femur, there, an excellent result about a year later. Another proximal femur non-union, same procedure, plating and a good result. Few more examples of proximal third non-unions. Somebody has dynamized them as well. And then neck shaft combination is again a combination which leaves one of the fracture non-united. In this patient, this fracture was not uniting. Simple procedure, plating and bone grafting. Another interesting patient, fractured neck, comminuted mid shaft and a supracondylar. The cavity was very narrow and she was, the patient was a female, so I did screws of the proximal fracture, and then a retrograde tibial nail was selected because 9 millimeter was required, and I never had a nail for femur, so I used a tibial nail. This fracture went into non-union, and we did again plating and bone grafting. Then some of these fractures which have minimal or no comminution, they can also go into non-union, dynamized, and again non-union, again this simple procedure and a good result. Similar patient has been dynamized by the surgeon as well as by the nature by breaking the screw. Again, plating, bone grafting, and look at the amount of callus. A very severely crushed lower limb, young girl, everything done primarily soft tissue coverage, thorough debridement, primary nailing. Again, in this patient, I had to use a thinner nail, so I went in for tibial nail in this girl. She ended up with non-union, and we had a very little soft tissue coverage, but again, I could go in, put a very thin plate, some bone graft, and she's standing tall on her feet. Then coming on to comminuted mid-shaft non-unions, a very common scenario. Again, similar procedure and excellent result. You can contour your plate if you want to or if it's required on the table, like this as a segmental non-union, contour the plate, bone graft, and reasonably good result. Another interesting patient, a segmental fracture, plated somewhere else. I think he was plated twice. And then somebody did a retrograde nail, dynamized also, still non-union, again plating and grafting. Then distal third non-unions, a distal femur fracture, treated with an antegrade nail and then strangulation with multiple wires. Simple procedure and good result. Few more examples. There's no place for unicortical screws. I had to revise 2 of my patients.
Time is over, sir.
Okay.
Please, quick.
Okay, I'll just conclude. So you can treat any long bone non-union with a simple procedure, plate and bone graft. And all fractures united except 2 of my patients. To conclude, plate augmentation and bone grafting, leaving nail in situ is a better alternative to exchange nailing in non-unions following nailing of comminuted and metadiaphyseal fractures of long bones. In non-unions of the fracture shaft femur associated with fracture neck, this technique leaves the proximal fixation undisturbed, so you don't have to disturb the proximal fixation and you can treat the shaft. Although exchange nailing is successful in non-unions associated with no or minimal comminution in mid-shaft diaphyseal fractures, the result of plate augmentation are better. Thank you.
Thanks.
Thank you very much. Any questions?
Yes, sir.
Yes, please.
Dr. Om Shah, Jodhpur.
Yes.
You have told that after non-union, after nailing,
Yes.
this is very simple procedure. You have made so long incision and bone graft
Yes.
and bicortical screw. It is not simple procedure. It is large procedure. And you have tried only bone graft in some cases without application of plate, then also the fracture will unite. And you have told that plate is to prevent rotation. When we have applied interlocking nail, putting 2 screw proximal, 2 screw distal, rotation is automatically prevented by the nail. And in after application, applying of intramedullary nail, if the fracture is transverse at the mid shaft, nail is snugly fitting in the proximal fragment. Only distal screw can give you union, no need of proximal screw.
So this is a
Thank
comment
you.
or a question?
Thank you. Yes. Yes, please.
You see, not all fractures will go on to healing if you bone graft them, and I only augment those fractures which have frank motion when you open up the fracture. If there is no visible motion, I will not go and augment them. I will just put a simple bone graft. There is no question about that. And most of these patients, they are either distal non-unions or proximal non-unions, where screws will not give you absolute stability in all your fractures. Agreed, many of them will unite, but if it's a non-union, there is reason to that. And that reason is always inappropriate immobilization of the fracture with your previous internal fixation. So you have to add something to these non-unions.
Yes. Thank you. Yes, Professor Tuli.
Sir, do you consider bipolar interlocking as a factory for producing non-unions?
Pardon?
See, most of your cases of non-union
Yes.
were bipolar interlocking.
Yes.
Interlocking at the upper end, interlocking at the lower end.
Yes.
Do you consider bipolar interlocking of long bones as a factory for producing non-union? Second question. When you do this procedure like plating, bone grafting, do you dynamize them as well by removing screws from one end, or if the nature has already dynamized, you may not do?
Answer to the first question regarding the nail acting as factory to producing non-union. Yes, of course it can. If somebody who is not very good at nailing, he starts nailing these proximal fractures or these distal fractures, some of their cases or even some of my own cases, they will go on to non-unions. And regarding, what was the second question?
Sir, when you start treating them
Yes.
by implant fixation and bone grafting or
Right.
bone grafting alone, at that time, if the nail has already been not dynamized
Yes.
naturally or by iatrogenic procedures, do you dynamize the nail at that time?
Yes, definitely, of course. If the patient come to me at the right time for dynamization, that's 3 to 4 months. Beyond dynamizing beyond 4 months or 5 months or 6 months, it's of no use.
Thank
so
you.
when they come at the appropriate time, I do dynamize only if the nail has a good fixation in distal fragment as well as in the proximal segment.
Thank you. Yes, Dr. Junjunwala.
This augmentation plating is a very good procedure. I feel that 6-hole plate is enough
Yes.
to control the rotation. The non-union is because of rotation. Axial, you have a nail, you have axial stability, and you get a rotational instability, that's why non-union.
Yes.
And therefore 6-hole plate, which produces a good stability in rotation, that is enough. And you don't require any bone grafting in such cases. Of course, you have to remove distal screws or proximal screws and dynamize it. Then only you will get a good compression at the fracture site at the non-union. Thank you.
Thank you, Dr. Junjunwala. Yes, thank you very much. I think we come to a close.
Dynamization should be done at the time of 3 weeks. At the 3 or 4 months, it is of no use.
Okay.
No,
Thank you.
3 weeks is no time for dynamizing. Appropriate time is 2.5 months.
No more discussion, please.
No more, please.
Thank you.
Thank you, sir. Thank you.
Professor Tuli.
Now, ladies and gentlemen, we have now eponymous oration, Dr. K.S. Grewal, eponymous oration by Dr. Surinder Mohan Tuli.
So I request you to please come and read the oration, sir. Read the particulars about Dr. K.S. Grewal. And after that, we will start with the talk.
Friends, I stand here singularly privileged to read about a great doyen in the field of orthopedic surgery, a person no less than Dr. Karam Singh Grewal. Dr. Karam Singh Grewal was not only a doyen of orthopedics in Punjab, but in the country and on the globe. He was born on February 4th, 1908 at a village known as Rai Singh Wala in an erstwhile princely state of Patiala. He passed his MBBS in King Edward Medical College, Lahore in 1933. He stood first in all the subjects in his MBBS. He was awarded gold medal for being the best graduate, joined state medical services and worked at very highly sensitive places, including ISA Khail, where he repulsed the attack on the hospital by Kabilis. Dr. Karam Singh Grewal joined Medical College Amritsar as lecturer in anatomy and passed his MS in 1945. Selected for higher training in orthopedic under the Colombo Plan. He worked in Royal National Orthopedic Hospital, London from 1947 to 49 with a Jackson Burrow Award. On return from England, he started orthopedic department in Medical College and Vijay Hospital, Amritsar, the first one in North India. Privileged. Professor, he became professor as early as 1958. His main interests in orthopedic surgery were congenital talipes equinovarus, which most of you know very well. He designed to split tibialis anterior transfer and relapsed clubfoot. Pioneer work in experimental production of Volkmann's ischemic contracture in monkeys to study its etiology, which became a clinical practice later on. Surgery in poliomyelitis, he was very keen, including cerebral palsy, and in bone tumors, and he was also interested in fractures of the femoral neck. One of the main architects of Indian Orthopedic Association, house at Amritsar in 1955. That was the place it is claimed that the IOA started from, Amritsar, under his chair. Trained orthopedic surgeons who later on headed orthopedic department in various countries, in various states and in India. He presented and published many papers on different subjects of orthopedic surgery. And Professor Tully also had although I never had the privilege of working with him, but Dr. Tully, who is giving the oration, he had the privilege of working with him, and I invite Professor Surinder Mohan Tully to read his oration, eponymous oration on his pet subject, tuberculosis, tuberculosis and tuberculosis.
Friends, it's a rare honor for me to give an eponymous talk, and that too in the name of Professor K.S. Grewal, a person who made me interested in orthopedics and a person who initiated me to this beautiful and vast, rewarding discipline. You are all warm-hearted people. I request you to show me more warmth by coming to the front seats which have been lying vacant since morning. Kindly give me more warmth. Osteoarticular tuberculosis is a challenge since the arrival of man on Mother Earth. It has existed with human beings since times immemorial, and it is present even today.
You need it.
It kills 3 million people per year, the highest number by one infectious disease. And 1/5 of the total world population of tuberculosis patients is in India. The Western countries, they diminished the incidence of tuberculosis from this high level to this high level much before the availability of chemotherapy and BCG. And that was a reflection of the effect of nutritional states of the society, because most of tuberculosis centers around cell-mediated immunity. If the cell-mediated immunity is low, one can get tuberculosis. There was a short-lived optimism between 1985 for about 10 years that probably we as human beings will be able to conquer tuberculosis. Unfortunately, that was a short-lived impression. And since 1985, the incidence of tuberculosis is increasing all over the world. Amongst the poor countries of the world, it is endemic. Whereas even in the rich countries, the incidence is increasing. The cause of incidence is there are always pockets of deprivation in the world. So long as there are pockets of deprivation in the world, TB will come, find a good host, persist and transmit. The rich countries are a little afraid of us because there is interglobal migration of people. There are haves and have-nots. All haves will have to interact with have-nots, and then there are chances that we may get tuberculosis from those people which are almost acting as culture media for tuberculosis. I think one of the important things which we must understand is skeletal tuberculosis. Clinically manifest skeletal tuberculosis is only a localized manifestation of a systemic disease. If we could do a generalized survey of every patient of skeletal tuberculosis, you will find that 40% of them have an additional active, though subclinical lesion. Here is an example of a specimen from a museum. One can see tuberculosis of the spine, which is present in so many vertebrae in the vertebral column. Here is another example of that we created an experimentally produced tuberculous lesion in the femur. The injection was made in the femur, but by the time the animals died, they had tuberculosis everywhere in the body. When I entered into orthopedics, every patient of tuberculosis was put in a plaster. It was a plaster spica, shoulder spica, or a plaster bed for a tuberculosis patient, and the aim was to obtain a fused joint. This tendency changed with the availability of anti-TB drugs. When the anti-TB drugs were available, we enjoyed the triumphs and euphoria that probably we are going to conquer this disease. And here are a few examples. Tuberculosis of the hip joint shown in the X-ray shows you a destroyed hip joint, destroyed acetabulum, and in the MRI one can see a collection of the fluids in the hip joint and a suppurating lymph node. Patient was treated by anti-TB drugs by a standard method of treatment which was given the name by functional treatment of osteoarticular tuberculosis. Give rest to the part in the best functional position, put them on anti-TB drugs. As soon as the pain subsides, put them on active assisted exercises of a particular joint, and you can probably heal many of these cases with practically full range of movements of the knee or a hip or a shoulder if you have made the diagnosis at a stage of synovitis. Here is the example of the same patient. See, at the time of presentation and 1 year after. This patient was treated by drugs on domiciliary lines and giving rest to the hip joint for some time till the pain subsided. If we look at the tuberculosis of the joints in general, it can be classified as stage of synovitis and different, see this is stage of synovitis, earliest stage. Today we have the facilities. The new generation is fortunate to have the facilities of imaging modalities. We can today diagnose a patient of tuberculosis at this stage. If we can make a diagnosis at this stage, you can heal this patient with standard drugs, functional treatment with full recovery of a joint. However, if a patient comes to you at a late stage, the recovery with full range of movements become less. And if a patient comes to you with a fused joint, after completion of the growth for elbow, hip, one may obtain a fairly mobile joint by doing a biological arthroplasty like axial arthroplasty and also do replacement arthroplasty in major joints once the disease has healed. Let's see a few examples of the efficacy, the triumph and euphoria which we got by treating these patients. Patient treated probably about 40 years ago early case of tuberculosis of the right hip joint at the time of presentation, 1 year after, 15 years after. See, the disease has healed somewhere in 1981. The hip joint shows healed status, but there is a coxa magna. Coxa magna can be present in a patient if the disease has occurred in childhood and the hip joint has remained in a hyperemic state for a few years. And any of the diseases can lead to coxa magna. And the same patient, roughly 40 years after the disease, patient is now developing degenerative early osteoarthrosis. The patient, however, has enjoyed this status. He can squat, he can sit cross-legged, but he has enjoyed a mobile, painless, effective, useful hip joint for about 40 years or 44 years. And now is the time that you can think of a fusion if need be. So this is the euphoria and the triumph which we have been able to get, that if you diagnose them early, treat them well, you can give them a mobile joint which is painless, useful, natural. A few more examples at the time of presentation 1 year after, and this is there's the same patient, there's another patient, a childhood. So you can see the draining sinuses here, pulmonary tuberculosis, and the patient at the age of about 7 years almost shows you a complete range of movements. Those patients who got a fixed joint, those patients who presented late and got a fixed joint, either by fibrous ankylosis or bony ankylosis or ankylosis in a bad, unacceptable position, could be provided a mobile joint by doing the procedure which has been given the name of Girdleston's axillary arthroplasty. Girdleston axillary arthroplasty permits you a full range of movement of the hip joints. This whole area gets converted into fibrocartilage. It is never a hyaline cartilage, and the patient would be able to. This is one of the one-time operation which can be found useful by the people working in the rural area. They can squat on the floor, work on the floor, what we call floor activities. A rich society, there are many people who don't require floor activities, but in societies, especially people in rural areas, require to work with floor activities, and this is one operation which permits you almost all floor activities except that the patient has 2 to 3 centimeters of additional shortening, and he may require a support while walking outdoors. If the patient is unstable after the axillary arthroplasty, there are two procedures which one can do. One of them is that you do a pelvic support osteotomy, something resembling this. In the lowest picture you can see something resembling this. Just do a pelvic support osteotomy, and if still it is found unstable, you can add to it a supraacetabular shelf. This young girl had to undergo an axillary arthroplasty. Look at the number of the scars she has on the lateral side of the thigh. After this procedure, axillary arthroplasty, pelvic support osteotomy, and a suprapelvic shelf, the patient is able to stand absolutely square shoulders. She is not showing any sign of a Trendelenburg situation. She can squat on the floor, sit cross-legged. Similarly, in the knee joint. Now this is the knee joint who had early arthritis, treated by functional treatment, range of motion exercises, no plaster, but non-weight bearing exercises from the very beginning, and one can see that the patient has a useful range 0 to 100 degree without doing any fusion or plaster leading to ankylosis. May fuse major joints only for absolute indications. I think fusion of a major joint today should be considered a serious operation. Let's not fuse hip joints, knee joints and lumbar spine just for trivia. Don't fuse them for trivia, because in the long run they put a lot of disadvantage to the kinematics of the adjacent parts of the body. Here is an example of a patient fused probably by me only about 50 years ago. A young girl was fused. We fused it in neutral position, but some degree of varus has taken place, and you can see the amount of stress she has. She has a stress on the lower and she has a stress on the ipsilateral knee, contralateral hip joint and the spine. With minor injury, she gets a fracture of the tibia once, and After some time, she gets a fracture of the femur. These operations should not be considered harmless operations. I think we should be very hesitant to operate on these major joints causing fusion. Today, we have the options to provide a mobile joint, provided you have reached a status of healed status. Today, these joints can be treated by, if not axial arthroplasty, one can treat them by arthroplasty replacement procedures. The provision is that the disease should have remained healed clinically, laboratory, and X-ray or imaging wise. 3 years of healed status, one can consider these patients for replacement arthroplasty. However, whenever such patients are offered replacement arthroplasty, do keep it in mind, you must cover them by anti-TB drugs para-operatively for a few months. We will come to them after some time again. So articular tuberculosis, there are so many operative options available to us. Doubt in diagnosis, operate. Unresponsive to multiple drugs, operate. Recrudescence despite drug therapy. Painful ankylosis in healed status. Ankylosis is painless or painful. Painful ankylosis does need treatment. Painless but unacceptable ankylosis, painless movements in non-functional arc. You want your joint to be in functional arc, then you do osteotomies or other procedure to bring a painless range of movements in non-functional arc to the functional arc. With all this euphoria, if you are observant, we will keep on coming across such patients, refractory patients, patients who don't respond. If you are observant and if you are working in a general hospital, not in 5-star hospitals, in general hospital, that is what my country is. We will have patients who are not responding to what you think is a first-line drug. 5 to 10% of patients don't respond. Recrudescence occurs in 2 to 5% of patients. And this is what we call multi-drug resistant tuberculosis. Today, the definition of multi-drug resistant tuberculosis is resistance to INH and rifampicin. It is a microbiological definition. You must harvest the mycobacterium, then only you can have this designation or diagnosis. Unfortunately, in bone and joint tuberculosis, at least in the northern part of the country, we have not been able to isolate or harvest mycobacteria in more than 20% of specimens. So, in other words, we will have to accept a designation as therapeutically refractory cases. Another class is coming up, XMDR. MDR plus resistance to fluoroquinolones and one injectable drug. This is one of the most terrible things which is coming up as a challenge to all of you. XMDR, do whatever you like, at the end of 5 years, most of them die at this stage in 5 years' time. Why do we get MDR? Why do we get resistant cases? One of the reasons is lowered MCI. Here is an example of lowered MCI, lowered cell-mediated immunity, CMI. Here is an example in front of you. Look at the patient. He developed disseminated tuberculosis because his cell-mediated immunity was compromised. He has an active lesion in the skull, humerus, elbow, spine, ribs, both the knees, histologically proved. Here is another example. Mother of a doctor, rheumatoid disease, you can see her hands on immunosuppressive drugs like methotrexate for more than 2 years. She comes back with discharging sinuses around the elbow. Do keep it in mind, use immunosuppressive drugs very, very carefully in our country. Mycobacterium tuberculosis is practically ubiquitous, present everywhere, floating in the air. And if your cell-mediated immunity low, you can get reactivation or formation of the disease. You can see discharging sinuses around the elbow. Here is the X-ray of the same lady. A biopsy was done which showed this tuberculosis. Tuberculosis can mimic anything. That also we have to keep it in mind. Here is an X-ray and MRI of a patient who looks like classical avian. But when we were doing core decompression, it was found that on the right side there is histologically proved tuberculosis. Another example of disseminated tuberculosis, even under drug, under treatment, the patient develops other active sinuses. And we should also keep it in mind that atypical mycobacteria can also produce tuberculosis. Here's an example of a patient picked up by one of my younger colleagues, funny looking osteomyelitis, not responding to drugs. Ultimately it was found that the patient is HIV positive, and the microbiological examination showed us this is Mycobacterium avium complex. Can we sometime have tuberculosis caused by two mycobacteria? Here is an example, possibly. Young man came with paraplegia, operated. I thought adequate mechanical decompression done. Patient recovered, walked for 1 year. And after 1 year, the patient comes back again with this appearance. Another lesion in the lower part of the spine, disseminated tuberculosis in the brain, multiple tuberculomas, tubercular meningitis, and the patient became paralyzed again. One can see probably tuberculous myelitis has taken place in the contents of the dural tube, probably a patient whose one mycobacterium responded and the other mycobacterium did not respond, probably a case of polymycobacterial disease. Here is an example of recrudescence, 1980 to 1987. One can see that in 1987 the patient came back with a recrudescence. I can see my time is flying, and these are two other cases who came back with a recrudescence. Keep it in mind that the patient is going to survive for 20 to 50 years, maybe 40 to 80 years now. With longevity, many of these patients will come back to you. Our collection is roughly 2 to 5% of these patients who had a healed status once came back to you with reactivation of the disease. This young lady was a girl when she was operated. She stayed with a girdle stem. From a girl, she became a wife and a mother, and 20 years after she comes back with tuberculosis of the sacral joint again. This patient, you can see a calcified psoas sepsis, which is there with the patient for the last about 40 years. Patient comes back again with a reactivation of the disease because the patient became now a diabetic. Implants and tuberculosis, I think I'll skip. Do keep it in mind, implants will perpetuate tuberculosis infection. The surgeon has shown his dexterity, hopefully stabilizing an unstable spine. Is it unstable? And this is the follow-up of the patient. One can see the screws, persisting abscess, draining sinuses coming out of the skin. Both the views are showing you coming out of the skin. Same patient. Another example. Putting an implant in the infected area. The surgeon wanted to stabilize this area. And here is the implant which has led to a pathological dislocation and debonding of the graft, debonding of the implant. I would make a request to the new brave generation. If you have put in the implant, you should also have the capacity to remove it if needed. On the whole, if you look at it, about 2% of implants required to be removed for one reason or the other. The implants placed in front of the vertebral column are not removable easily unless you get a DOT permission. Even the primary surgeon will not remove these grafts. Unfortunately, the patient remained paralyzed. You can see the scar through which we went, or scar through which we as orthopedician surgeon went, persisting sinus more than 6 years after, patient in an indwelling and on a wheelchair. Persistent chronic ulcer in a case of knee joint replacement, limitation of diagnosis. I think I'll go to the last picture, that these are the challenges for the future generation. The future, bright, brave, new generation of orthopedic surgeons will face all of them. MRI picture, though sensitive, are not specific in 10 to 15% of patients. lesions with clinical and imaging diagnosis of tuberculosis, histology comes only as tuberculosis only in 30% of patients. In 70%, the reports are as inflammatory appearance, which means that in these patients, you will have to observe your clinical acumen and write it down on the paper that you have tried everything, so I am starting the drugs on clinical basis. Mycobacteria can be harvested in less than 20% of pathological specimen. Resistant to first-line drug is emerging at about 8 to 10% of patients. Having achieved a healed status, follow-up of more than 20 years will show you recrudescence to 2 to 5%. At best, we can use a status of lasting healed status. I don't think we have any right to use the word cure stage of the disease. Do kindly keep it in mind, mycobacteria still persist in the human body in macrophages, in cells, in the tissues of the body. They are only waiting to start replication if your cell-mediated immunity comes down. I am thankful to my teachers who taught me. Professor Grewal for initiation, Professor Sankran for operative techniques, Professor Durasamy who taught me orthopedic biology and philosophy. And he was the person who taught me anything can be better than what we are doing today. I plead to the new generation, the new bright and brave orthopedicians, let us face the challenges in our country and try to find solutions. Thank you, sir. Thank you.
Thank you, Professor Tuli. Since it's an eponymous lecture, there are no questions on this. And thank you very much for your patient hearing. And now I think it's valedictory function. Professor Kapoor. So what are we supposed to do now?
They will come. We have to leave.
Yes. Thank you.
Hello. Good morning, gentlemen. Sorry for the delay. We are running slightly late because of lot of formalities. May I invite Dr. Saurabh Agarwal to speak on ultrasonographic evaluation and monitoring of correction of clubfoot by Ponseti technique and its detecting spurious corrections. Dr. Saurabh Agarwal, please.
Thank you, sir. Thank you, organizers, for inviting me for this lecture on ultrasonic evaluation in correction of clubfoot. I brought greetings from Jhansi, the land of Rani Lakshmi Bai. As we all know, Ponseti method is the gold standard for treatment for idiopathic clubfoot in the present decade. The technique involves toe to groin serial plaster of Paris casts followed by a tenotomy if required to correct the equinus. The basis of the technique is the kinematic coupling of the calcino-forefoot pedal block. That is, the abduction of the midfoot acts as initiator to correct the inversion and the varus deformity at the hindfoot. For the evaluation of the correction and for serial evaluations, we can use both subjective methods and objective methods. The subjective methods in popular use are the Pirani scoring system, which involves a midfoot and a hindfoot score. The maximum score is 6. The other popular system is the Dimiglio classification, which involves the evaluation of the equinus, the varus, the adduction, and the derotation of the calcanopedal block. The demerits of all these subjective systems are that they are subjective. First of all, both they have intra-observer as well as inter-observer bias. The objective assessment methods which can be used are photography, photography and radiology. For photography, it can be used for correction for documentation purpose, but the statistical calculations are difficult and again have inter-observer bias by different views of the foot. The photographic evaluation, though, is a better system, but the demerits and difficulties are, it is very difficult to see for the correction of the equinus, and moreover, it cannot detect the spurious corrections. The radiological evaluation methods used are the X-ray, MRI and ultrasonography. The problems with the X-ray are, it gives inaccurate measurement because of the unossified small eccentrically located ossific nuclei. Moreover, it has radiation hazards. The MRI, it is expensive, requires sedation, not readily available, difficult as a tool for serial evaluation. The ultrasonography, with ultrasonography the advantages are the cartilaginous components can be well visualized with easily. It has a dynamic capability, that is, it's a real-time study. It can detect spurious corrections. No anesthesia is required. It's a OPD procedure, inexpensive, and can be serially used for evaluation. It has inter-observer bias, but it can be eliminated by performing ultrasound by 2 radiologists specialized in musculoskeletal sonography. The method, we use a ultrasound machine with a 5 to 10 megahertz linear transducer. 26 and 45 mm probes are used. The foots are sonographed in both neutral and maximally corrected simulated position using a simulated Ponseti maneuver. The non-ossified bone gives a black, that is a poor echo on ultrasound, while the ossified bone gives a white, the bright echo on ultrasound. The projections that are to be done are the medial projection, lateral, dorsal and posterior. For the medial projection, we place the transducer on the medial border of the foot in slightly oblique or vertical direction in line with the talus and tibia to match the degree of equinus. It's similar to a AP radiograph of the ankle. We place the transducer in its slide on the medial border of the foot. The parameters to be assessed are the MMN distance, that is the medial malleolus navicular distance, which is the most important criteria, medial soft tissue thickness, the navicular relation to the head of the talus, and the mobility of the talonavicular joint, which can be assessed on dynamic sonography. MMN distance is the distance between the tip of the medial malleolus to the medial end of the navicular. It increases with treatment. As the foot is corrected, it increases. It indicates the severity of the deformity in the talonavicular complex. The medial soft tissue thickness is the perpendicular distance from the skin surface to the medial border of the cartilaginous talus at the level of talar ossification center. It decreases with correction. The navicular relation to the talus can be graded as no displacement, less than 50% medial displacement, more than 50% medial displacement, and complete navicular subluxation, which can be very well seen on ultrasound. The dynamic sonography, we can see for the mobility of the talonavicular joint. Again, its reducibility can be graded as grade 1 to 3, no mobility, intermediate, and if it can be very well reduced to normal position, grade 3. The lateral projection, we place it on the lateral border of the foot, parallel to the plantar aspect. The criteria assessed are the calcanocuboid distance and the calcanocuboid angle. The calcanocuboid distance is the distance between the tangent to the calcaneum and to the midpoint of the lateral border of the cuboid. It decreases with correction. The angle is the calcaneocuboid angle is the angle between the two tangents, one to the calcaneum and one to the ossific center of the cuboid. Again it decreases with correction. Third projection is the dorsal projection. The transducer is placed on the dorsal aspect but slightly more laterally to follow the main direction of the talus. The parameters assessed are the length of the talus and the talonavicular relation in the sagittal plane. The maximum length of the talus increases with correction. Fourth projection is the posterior projection. The transducer placed on the posterior aspect, partly on the heel and partly on the foot. The posterior projection, the parameters assessed are tibiocalcaneal distance, which denotes the tibiocalcaneal relationship in the ankle and the ankle mortise. It can again be assessed on dynamic sonography, whether it is reducible or not. The posterior compartment soft tissue thickness and the tendo-Achilles length. This is the normal posterior projection showing the skin. In the center is the tendo-Achilles, and we can very well see the posterior aspect of the tibia. The tibiocalcaneal relationship denoted by TCL distance is the distance between the distal ossified metaphysis of the tibia and the calcaneal ossific nucleus. It increases with correction of the equinus. Posterior soft tissue thickness, distance between skin and the posterior tibial cortex. It decreases with correction. The length of the tendo-Achilles from musculo-tendinous junction to the distal insertion, it increases with correction. Now what is spurious correction? That is, the foot appears corrected clinically, but the tarsals are not well aligned. There is a break at the naviculo-cuneiform joint, mediocuneiform shifts lateral to the navicular, leaving the navicular subluxated. By ultrasound, we can see, very well see the spurious correction. The navicular is prominent medially and it seems locked to the talus. Clinically, the foot going in spurious correction are seen to be rigid. Another advantage of ultrasound is the dynamic capability, that is, the mobility of the talonavicular joint and the reducibility of the talus can be well assessed. These different criteria correlate well with the different clinical criteria. That is, for foot adduction, we can see for the MMN distance, the soft tissue thickness on the medial side, the calcaneocuboid angle. For derotation of the calcaneopedal block, again MMN distance, MS soft tissue thickness and the calcaneocuboid angle. For equinus, the tibiocalcaneal distance is the best criteria, and for hindfoot varus, the calcaneocuboid angle. These are some of the examples. We have done the ultrasound. The MMN distance has increased in the second ultrasound after correction. That is the final ultrasound. Again, the calcaneocuboid angle has decreased. This is the talar length which can be seen on the dorsal projection. It has increased. This is the tibiocalcaneal distance. Another case, again the MMN distance has increased. Calcaneocuboid angle has decreased. The talar length has increased. And the TCL distance has, that is the tibiocalcaneal distance, has increased. Thus, ultrasound is a relatively simple, non-invasive and widely acceptable procedure that can improve the pathomorphological documentation of unossified clubfoot. It allows for objective monitoring of the progressive correction of clubfoot. It detects spurious correction and has dynamic capability. It's a promising technique for assessing and monitoring of clubfoot treatment and should be a part of the neonatal assessment of clubfoot. ICFSG has included ultrasound examination in the initial assessment of clubfoot deformity to increase its widespread use. Thank you.
Thank you very much, Dr. Saurabh. Now may I invite next speaker, Dr. Ajay Singh, who is going to speak on what is new in the basic science of fracture healing. Is he here? He is here? Dr. Ajay Singh? No. Is Is any of the other speakers available here? Sir, your good name? Dr. Anil Gupta. Yeah. Please, please.
Good afternoon, my respected seniors and colleagues. Ligamentous Lisfranc injury is a bony or ligamentous injury involving the tarso-metatarsal joint complex. The tarso-metatarsal joint involves the 3 cuneiforms, cuboid and bases of 5 metatarsals. It is one of the few injuries in orthopedics where the maxim, the eye do not see what the mind does not search for, is appropriate because it requires a high degree of clinical suspicion. In 20% of cases, it is misdiagnosed, and 40% of times, no treatment is taken in first week. The hyperextension of the forefoot is the cause of injury, either catching the forefoot in a hole in the ground or horseshoe back rider falling and hanging the forefoot in the stirrup. The symptoms may be midfoot pain, difficulty in weight bearing, swelling across the dorsum of foot, and plantar ecchymosis. The plantar ecchymosis may appear late, but if it is there, it is highly suggestive of midfoot injuries. On physical examination, apart from the other thing, look for the status of dorsalis medius artery and posterior tibial pulses. Radiological evaluation requires AP, lateral and 30-degree oblique view, especially the standard stress view of the both feet to compare the injury. In AP view, first metatarsal aligned with the medial and lateral border of the medial cuneiform in normal bone. On 30-degree oblique view, the medial border of the fourth metatarsal is in line with the medial border of the cuboid bone. Lateral view, there should be uninterrupted line across the dorsal surface of the second tarso-metatarsal joint. There are some suspicious signs.